From the Zoomerplex in historic Liberty Village, The Zoomer, hosted by Libby Znaimer. Welcome to The Zoomer. I'm Libby Znaimer. Today, we're diving into a deeply important and personal topic, breast cancer and survivorship. I was diagnosed with breast cancer back in 2006. I was lucky. It was early stage and straightforward to treat. But that's when I found out that I had a genetic mutation that put me at risk for a long list of other cancers as well, and I had to make difficult decisions about surgery and treatment. And after it was finished, I had a very extensive regimen of screening. The good news is that advances in treatment and survival mean that, like me, hundreds of thousands of breast cancer survivors are alive in Canada today. Each one lives with a new reality after the treatment, and that is what we call the new normal. What are the key physical and emotional challenges? Let's start with the physical fallout, and let's begin with Dr. Nadler. So what are the key physical things people have to deal with after treatment?
That's a very big question, and it always depends on what kind of treatments they've had. So I'm sure Dr. Lim, who's the surgeon to my left here, can talk a little bit about, for example, just the physical changes after the surgery, changes to the shoulder and range of motion. But for example, if people need endocrine therapy or chemotherapy, they can end up with neuropathy, numbness and tingling. They can end up with muscle weakness. They can end up with pain in their body from the chemotherapy regimens, deconditioning, and anything else that maybe they experienced a blood clot because of their treatment. So it really depends on what treatment they've had, but there's a whole realm of different types of physical side effects of treatment.
Touching on the surgical treatment, women following breast cancer treatment can be faced with a variety of survivorship concerns. The important one relates to body image and self-confidence. When we think of women who've had lumpectomies, they may, when they look in the mirror, see any cosmetic defects or asymmetries. If they've had a mastectomy with or without reconstruction, it may look like breasts, but it doesn't feel like breasts anymore. This has impact on sexual well-being. And sometimes looking in the mirror reminds them of the cancer that they had. And so it's trying to get over that and to embrace the new normal.
Dr. Cullen, there's pain after breast surgery, and you're involved. You're starting a new study on that.
Absolutely. Pain is actually quite common in breast cancer survivors, and it's estimated that approximately 1 in 3 will have long-term pain. For most patients, it will be mild, but there's a good proportion that will suffer from severe pain. We are conducting one of the largest studies in the world right now, where we're looking to prevent persistent pain in breast cancer survivors. And we're utilizing a pretty simple and cheap medication to do so. It's lidocaine, and we're putting it into the bloodstream during breast cancer resection. Preliminary data suggests that it might be helpful, and we're conducting a large study to confirm that.
Dr. Cullen, you're a psychologist and a sex therapist. The first thing that Dr. Lim mentioned was self-image. I know that it can be very difficult for people, even losing their hair after chemo. What do you find? What do you see?
One of the things that we start to focus on is really allowing space for those emotions and that experience, really allowing space towards grief in service of acceptance or at least acknowledgement of where the body is at. And so a lot of the work I do is stage-based essentially. And so first is reconnecting with the body from an area of safety and privacy. A lot of women have spent months being exposed. Their body no longer feels like their own. We're also working to help women connect with their bodies from an area of confidence and self-esteem, which certainly has a big impact or is certainly impacted from cancer. And then working on things like reconnecting with the body from an area of sensuality and sexuality. And of course, this really depends on a woman's cancer journey and where she's at.
Let's talk to Fernanda. You've actually gone through this quite recently.
Yeah.
So.
For me, it's almost a sense of, it's kind of like a new type of body dysmorphia. You look at yourself and you know that's you, but you can't reconcile the image that you see in the mirror with who you are or who you used to be. And it's really coming to terms with accepting the fact that the person that you were before that cancer diagnosis no longer exists. And you are truly rediscovering every part of yourself as you try and heal yourself along the way.
Can I ask
Yep.
how that played out for you? I mean, frankly, you look pretty darn good to me.
I rest a lot. So for me, it's seeing your scars, seeing, this body doesn't look the same. You're tired, you're exhausted, you've put on weight. That also changes your perception of your body. And it seeing your partner's reaction to your body, even immediately after surgery and taking off your bandages and, seeing all of your bruising and just they try and mask it, but you can see the difference. Their demeanor changes. You feed off of that energy, which, feeds your own insecurity of what you see in the mirror. And it really does just do a number on you. It's not your body. That's not the body that you recognize anymore.
Okay, we'll have to leave it there. When we return, we look at the emotional challenges. Don't go away. Welcome back. For those who survive breast cancer after the whirlwind of diagnosis, treatment, and endless appointments, the words cancer-free should feel like a victory. But the fear of a recurrence is there, especially when it's time for follow-up screening. The anxiety that many experience when it's time for their scans has actually led many women to ask for preventive mastectomies. Kim, I know that before people's follow-up scans, they can get really, really stressed. I remember at the beginning, I used to try, I had a strategy, it's like, you can worry about this for an hour, then you have to think about something else. It worked for me, but for some people, it can be really quite debilitating.
Absolutely, and that is in fact one of the strategies that I work on with clients, so you've got something right there, Libby. But I think the first thing is to just create space and normalize that this is absolutely an anxiety-inducing experience. Anxiety is our body's natural response to uncertainty and or perceived or actual threat. And so what we want to be doing is not expecting to go into this with zero anxiety, but in fact doing things to address and downregulate the stress response. And so first and foremost, what we can do is educate ourselves and gain some information. We know that obtaining accurate and reliable information is in itself a stress management strategy. So speaking to your physician or oncology team about what exams and follow-ups entail. The next is to create a bit of space for balanced thinking. And so we want to expect that frightening thoughts will undoubtedly occur. And so when we notice these thoughts happening, we want to create some space and label those thoughts and notice ourselves having them in service creating a bit of distance. We also want to create some space for positive or neutral thinking. And so this isn't that kind of toxic positivity that we know isn't helpful, but also understanding that there is a possibility that the scan or the result will come back negative and thinking about how we would feel. We also want to be engaging things absolutely, like creating a specific time to worry. We don't want to be telling that worry not to exist, but in fact creating a limited amount of time. And also turning to things like distractions. If we are thinking, particularly coming up to an exam where we know we are going to be particularly anxious, to keep our minds and ourselves busy, and that can include bringing in supports.
Supriya, you had a department of imaging, and it's the imaging that, what do you see in terms of women coming in, and what's your response to it?
So we spend a lot of time with women actually when they're going through their treatment and afterwards, and often they're in the middle of their chemo cycles, and you can see their entire life kind of unraveling in front of your own eyes. And it's the time when they want to talk because they find us in a dark room lying down. It's a very vulnerable situation when they're coming for their ultrasounds. But all these conversations that we've just had just underscore the importance of early detection. because all the side effects, I mean, the chemotherapeutic agents have become very advanced, very useful, very targeted. But ultimately, finding the cancer early means you'll have less treatment, which means there's less disruption of your day-to-day life, and there's less side effects. I mean, we just spoke about so much of it right now.
What was the most stressful part of that for you?
Remarkably for me, I think active treatment was probably the least stressful because there was always another milestone in place. So it was like, okay, I've got chemo session 1 or surgery, and then I'm going to the oncologist 2 weeks. I'm going to start chemo session 1, then there's chemo. You're always looking to the next milestone. But when active treatment ends, and I remember, you know, my last radiation treatment at PMH, and I just remember walking out and just feeling like, oh, what happens now?
They've abandoned you.
Right? The cheerleaders aren't there anymore. And you're kind of, you know, you feel like you're at the end of this race, but nobody's there. And it's just kind of like, what do I do? Like, but you still feel not so great because you're tired from radiation. I was still tired from chemo. You know, I'm still spending the vast majority of my day in bed because for me, the biggest side effect was fatigue, and still is. So it was sort of, and then the flooding of emotions come in, all the stuff that you didn't have time to process because you were in active treatment, or all the things that you masked along the way, all those emotions that you sort of covered up because you didn't want your kids to get scared, or your mom or your partner or whoever else around you. All of those come flooding in when you have those quiet moments, and there's not another treatment ahead, and you're not scheduled for follow-up for 6 months.
Now, to both of you, the oncologists, so I remember that it's starting in the wake of Angelina Jolie talking about her genetic mutation and her prevented mastectomies, the demand for that went up. And I was a little kind of outraged by the whole thing. I said, you know, mastectomy is not a treatment for anxiety. And I was kind of set straight by some doctors and oncologists, and they said, look, it is so stressful for people that it can be a reasonable treatment. I mean, I have friends, like a friend of mine, she spent 7 years trying to convince her surgeon, who finally said yes. I mean, you know, frankly, I thought it was beyond the pale. So what do you think of that, and is that a thing now?
It's a really good question, and it comes to understanding the patterns and the types of recurrences that people with breast cancer can have. And so me, as a medical oncologist, I look at features of the breast cancer, the size, the number of lymph nodes, the receptors, and I always think, well, what are the chances actually the breast cancer could come back in the rest of the body? So what's called stage 4 or metastatic. So could the breast cancer actually come back in the bones or the liver? And the worse those features are, the more treatments we recommend. But what's really important to remember is that doing a mastectomy, even on the side of the cancer, or doing a prophylactic mastectomy on the other side, unfortunately doesn't stop that from happening.
Exactly, and breast cancer doesn't usually recur in the other breast.
Correct, yeah. If it's a quote, you might have a new cancer in the other breast, but you're right, it doesn't recur. And that's not to say that this strategy is for nobody ever, none of the time, but it's really, really important that we take that step and we explain what I just did so that people understand the different types of recurrences or the different types of new breast cancers and how that factors into the decision making. So we know that doing a mastectomy on the other side won't improve survival. But for some people, after thinking about it and discussing with their oncologist, it may end up being the right thing for them.
I think patient education is really important. Some patients, because of tumor factors, they have just large tumors, lumpectomy is not a choice. But for the women who do have a choice between lumpectomy and mastectomy, I make it well known that there's no difference in oncologic outcomes, so that includes recurrence and survival. And then when it comes to removing the other side preventatively, I make sure that they're aware that in the absence of a genetic mutation, it does not improve a positive genetic mutation, it doesn't improve survival. And we also, from the point of view of the surgeons, additional surgery or more extensive surgery can be associated with surgical complications that can delay their additional treatments like radiation, for example. So I try to ensure that the patients are well informed and they can make an informed decision. We certainly don't recommend or condone prophylactic mastectomies for everyone. There are still some women, despite all that information, that's what they're most at peace with, is to have the double mastectomy. And then from that point of view, I think different surgeons will have different opinions. Some surgeons will just outright say no. Other surgeons will feel her body, her choice.
There's just one thing I want to touch on with Supriya, and that is women from disadvantaged communities and how different their response and their access might be.
There are women from with barriers like social barriers, economic barriers, racial barriers, like Black women or women of who are not white or not Canadian. They're immigrant populations. We see a lot of those here because they may not have family physicians. There's nobody to send them for screening. So there's always a higher likelihood that these women, when they present with cancers, they will be more clinically apparent, more advanced cancers, which obviously means more treatment and all the other things that we've already discussed. So access is very important for all kinds of medical care, but particularly for preventative.
We'll be right back with more of the Zoomer. Welcome back. For cancer survivors, recovery can take many months, and depending on the type of treatments you received, that will determine how long it takes. After successful surgery, though, 1 in 3 women can develop chronic pain, which has a big impact on being able to return to work and getting back into physical shape. Exercise is a huge factor in recovery, and diet is also important. Breast cancer often makes patients gain weight, as we said, as opposed to what happens in other cancers. Dr. Khan, tell us about your study on persistent pain.
And as a chronic pain doctor, I do have to emphasize that once chronic pain does start, it is very difficult to treat. By and large, most patients will continue to suffer in chronic pain for years and decades to come. So from a health economic point of view, it's important that we invest in prevention to offload those who will even develop chronic pain in the first place. So as alluded to earlier, we are conducting what's called the PLAN trial. So patients undergoing primary mastectomy or lumpectomy with or without reconstruction are eligible, and we are administering lidocaine into the bloodstream during the time of breast cancer resection. And we'll follow up with patients 3 months and 1 year after surgery to see if we can decrease that incidence of 1 in 3. So drive down that 33%. On the other end of the spectrum, we have programs and research dedicated towards treatment. Treatment for chronic pain in general, there's some good options, but a lot of things currently have side effects. And so we need better treatments that are safer, have less side effects, and more widely available. And so we're looking at things like non-invasive therapies, things where we can target nerve and do what's called neuromodulation. And then exercise is also a big component of treatment. So both physical therapy, but also occupational therapy. Many of these patients want to go back to work, they have caregiving responsibilities, and finding ways how they can manage with pain. Sometimes pain resolution isn't possible, but managing in pain to meet their lifestyle and life goals is important to give them the tools to do so.
One of the focuses of my academic work is how can we make sure that after treatments are done, when there are side effects, that people are told, exercise can be helpful, and that people are referred to appropriate programs to help them meet their needs. So for example, some people may just need some social support to exercise. Maybe they want to exercise with other breast cancer survivors, and there are certain programs for that. Some people may need very specific rehabilitation or exercise. For example, it's difficult to lift weights if you can't move your shoulder. So they may need specific rehabilitation for the shoulder before they can engage in exercise. And some people need a full comprehensive rehab program, which, like James explained, will look at the whole picture. So a lot of the work I'm trying to do is to make sure that everyone has the opportunity to be referred to a program or to a service that can help them. And I think hopefully also that may be something emotionally that's helpful for patients too, because then you have that next step after treatment. So it's something I try to discuss with patients. Okay, when you're done, is you have radiation, but we also have we're lucky at Princess Margaret to have a great cancer rehab program, and it would be great if this was accessible to more people.
What about people, I mean, I've known people, they need a push. They just need a push. It's like they say, like, you don't know what I've been through. I just can't. I just won't. And sometimes I nag them. It doesn't help.
Yeah. Well, like Dr. Nadler said, like we do have an amazing survivorship program here at Princess Margaret, and that's something that I'm grateful to be part of, right? And that includes a whole interdisciplinary team with a physiatrist that addresses like kind of the physical components of it, like lymphedema, the physical limitation, like pain, neuropathy, right? And then we have occupational therapists that actually help address that and also help with the return to work component. And then we have physiotherapists, we have a wellness chef as well, and then also a social worker to kind of also give that little push and that emotional support as well. And then also we have kinesiologists, which they design an exercise program and they keep those patients accountable for it as well.
Well, that's the part,
yes.
Accountable for it.
Yeah.
Did you go back to exercise? Did you find it
I
hard?
did. I did and am. I actually got referred to the survivorship program at PMH. And again, I kind of want to emphasize the access. I mean, I live within the city. It's really easy for me to get to Princess Margaret and to be able and do these programs. And that isn't an option for a lot of women in our province. So there are sometimes, you know, they might have to search for these things online, and that can be sort of its own myriad of challenges of navigating this because they don't know who to turn to. Actually, really fortunate. The program at PMH is fantastic. I just finished the CARES program with the kinesiologist, which is fantastic, and it has made a difference.
That's like a personal trainer that you get.
Yeah, they basically write up a program for you, check in with you every month, and it's for the first 6 weeks. She calls you weekly and makes sure that you're, sticking to your program until you get your routine down, and then it's monthly follow-ups. So it's a fantastic program. I just wish that it was expandable to other cancer centers and that there was more accessibility for other women in the province.
You actually need a person to push you through the whole journey fast. Otherwise, you get stuck. And I've seen countless women who say, I don't have a family doctor. What am I going to do? I'm like calling the surgeon myself and expediting. I'm sending emails and putting people in Dr. Lim's clinic, even though there's no family doctor. Because if you leave them, they're going to be just floating and waiting for weeks. And we don't know what's going to happen in weeks.
We need to take a short break. When we come back, we'll talk about post-cancer sex. Don't go away. Welcome back. The side effects of some cancer drugs and the physical changes that breast cancer can cause often have a powerful impact on self-image, self-confidence, and sex. Not to mention the burden on families and the shifting dynamics in relationships that can make it difficult to reconnect with a partner. So how do we improve sexual well-being after cancer? Dr. Kemp.
Well, the first step is to think about how do we approach even thinking about approaching sex. And we want to first give ourselves a little bit of space and reduce some of the pressure in any need to rush back to sex. And so this is a little bit of balance of knowing when you are perhaps not fully ready, but just ready enough. This is also a time where women are getting a sense of who they are and rediscovering that relationship with their body. And so that's another part of the work. When it comes to couples, one of the first things I say is that communication is really the bridge back to sex. And so it's really, really important for couples to have these conversations. It can also be quite unifying and connecting to know that your partner is feeling their own level of concern. We also want to be thinking about what our comfort levels are with respect to sex and where we're feeling ready. If in the moment you are not ready to show your body during sex, wear a nightie, wear a t-shirt. It's okay to meet yourself where you are at. I think one thing to think about is that women are also adjusting to not only a lot of physical changes, but changes within the relationship dynamic. And so thinking about things like transitioning from a relationship to patient caregiver back to romantic partners. And so this includes things like dating and spending quality time. And so it really is individualized. And in all of my sex therapy work, one thing we're really stressing is that there is no normal, there is no right way to have sex or be sexual, there is no normal trajectory. It's really being connected to what feels right for you. But again, knowing that you might never fully feel ready. So when you feel ready enough.
I know that even the hair piece is important for women, so I'll call up a picture of Libby bald. There we go. I had wigs, but there it was. Not great, not that sexy. What about pain during sex?
It comes up occasionally when we see these patients in clinic, and we try to reach for a multimodal management option to help improve their experience. And so as a medical physician, we tend to reach towards oral medications, some topical ointments, but also we have advanced interventional pain procedures where we can actually target some of the nerves that go to the pelvic area. Now, it's not very common that we do that, but we can help reduce any sensitivity, any discomfort that may arise with sex. It's not perfect in terms of the interventions, but we may try it and see if it helps.
Afterwards, you might be put on drugs that bring on, well, if you've had chemo, you're in menopause. But tamoxifen or aromatase inhibitors, that all will make it all more difficult.
Yeah, exactly as you said. So in young women or in women that are close to menopause anyway, unfortunately the chemotherapy jumpstarts menopause or makes it happen a little bit sooner. And so there's a lot of vaginal dryness or vaginal discomfort, and all of the endocrine therapies, as you've mentioned, can lead to either some unwanted vaginal discharge or vaginal dryness. Some women describe, that they may even have small tears within the vagina because it's dry and things aren't, lubricating the way they used to. So we often have conversations with patients first about using non-hormonal based lubricants, especially those with hormone-positive breast cancers, to use water-based, or now there are new silicone-based lubricants, which some women find helpful. But like Dr. James said, we have to try different things, and they work for some women and not for others. And then I very often have conversations with women with hormone-positive cancers where we discuss, the pros and cons, again, through patient education, about using a hormonal-based lubricant, the smallest dose for the shortest amount of time possible. And that will also be a very individualized conversation based on the breast cancer they have, their own risk tolerance, but also their quality of life, because quality of life is very important.
Do you want to talk about your experience?
I wasn't going to get into the nitty-gritty, but I think also going through it all, it does change the dynamic of your relationship, because you as a person have changed as well. There are many marriages that fall apart when breast cancer happens, and sometimes that's because your partner wasn't great at supporting you or didn't want to stick around to it, but also because as a person, as the patient, your views of things have changed, and you're a lot less tolerant of other people's BS than you used to be before. So it's just, that all changes. You're rediscovering who you are as a person, and the person that was your partner may not like that anymore.
Does this, do your patients talk about this freely in the office?
I often experience that because, it's very much like I'm asking those questions, how are your relationships, and providing that safe space, right? And oftentimes people are redefining their values, right? And I think it's really important to provide that space for them to navigate that situation.
And is there a cultural aspect to that as well?
Well, it definitely is. Like some cultures, they just don't want to talk about it at all. It's like two people living different lives. It could just end up being like that, especially when there's like big families, more children. So I don't think people ever get back to that kind of intimacy again. So it's highly likely in cultural barriers.
We'll have to leave it there. We have more after the break. Don't go away. welcome back. It's now time to turn the floor over to our audience. First, we have Maria. Hi, Maria. What's your question?
Hi, I was just wondering how you can support someone that has gone through cancer and how you could support them better, and also the caregivers as well, how they could support them.
One of the best things that some of my friends did was actually dropped off prepared dinners. That was like our favorite thing, because it was just, I didn't have to worry about what my kids were gonna eat. My husband didn't have to worry about, ordering in, and at least they got like a home cooked meal. So we had several friends that would drop off meals, and that was probably the easiest. And then I had a group of girlfriends on my street that, would invite me over for Sunday morning coffees. And it was just, if you wanted to talk, you could. If you just wanted to sit and gossip about what was happening in the neighborhood, that's what it was. And it was just no pressure, just sit with a blankie and a cup of tea or a cup of coffee. And
I think the most important thing is just show up. Like, don't ask, oh, I'll be here, let me know what you need, because most often people won't ask for that help. Just show up, be there, and I think that's like the most comforting thing for patients.
I would like to add a little bit more about caregivers as well. As rewarding as a caregiver role can be, it also has its own toll, and a lot of caregivers will actually experience the same, if not higher levels of distress than patients or survivors. So as a caregiver, we really want to be making sure that we are taking care of ourselves and being able to tune in on sort of your thermometer of your own distress. And so this means making sure that you've got a good set of informal supports like friends and family, thinking about organizations and support groups that are out there, because they do exist.
I think one of the things that I've seen that has helped my friends is friends just being available to talk, because there are things that you cannot talk with your spouse or with your kids or at home, where they need something outside who would be willing to hear. So that support, I think, is very critical. I mean, you must have seen that, but having peer support is very critical for going for their appointments with them, or just like simple things makes a huge difference, I've seen.
I was just going to say, giving somebody a drive and maybe giving a break to the caregiver who usually goes to the appointment. Though I have to say that if I took up every offer of a drive to treatment, I would be in treatment for my entire life. So, but yeah, I think that's really helpful. Thank you. I want to say something, and there's a certain culture around breast cancer advocacy which is very focused on being positive. I used to get like a lot of, frankly, nonsense, people saying, well, you're doing well because you have a positive attitude, and people being told if they don't have a positive attitude, they won't do well, and there's a lot of smiley faces. So that's one thing that doesn't allow people to express themselves. But also, I've also talked to women with stage 4. I've known women with stage 4 who lived for quite a long time, and they really feel left out of the areas of support. It just seems like it's not for them. They feel like it's all focused on people who are more likely to recover, and frankly, there are more and more of them who are around for longer as well.
the reality is, although you're cancer-free, you're never really free of cancer. It's the shadow that's attached at your heel. It's, as I mentioned to somebody earlier, it's like at the end of treatment, you become Peter Pan and you've discovered this shadow. Some days it's really big and some days it's really small, but it's with you till the end. So even though active treatment is there is still all of this other stuff that's associated with cancer that lives with you the rest of the way you go, even if you never get a reoccurrence, even if you never get a second cancer. There's still all of this byproduct stuff that you're left with, and that's what survivorship is.
And Libby, I'm so glad you brought that point up. I think this is something that so many survivors are experiencing, but are afraid or perhaps even ashamed to address, that this idea of ringing the bell or being the cancer survivor warrior just doesn't fit with everyone. So even in the context of optimism, we want to be mindful of our language and thinking about how that may or may not fit with someone. When I'm doing, for example, work on body image or sex, so many women will struggle with feelings of shame, that they should be grateful that they're alive, and is it okay to be grieving and feeling these things and feeling all of these other complicated emotions. And so the overwhelming answer is yes, absolutely. But I think as care providers and as a society and as support, we do want to be creating more space and just awareness that there is this invisible part of survivorship that we don't know is going on unless you've gone through it.
With a lot of cancers, I mean, 5 years is usually used as the marker you're cured. But with a lot of cancers, I've had very deadly cancers, pancreatic cancer, and they say, oh, it's not going to come back. But breast cancer can come back after many, many years, and often does, unlike other cancers, which may be overall deadlier.
Hormone-positive breast cancer is overall less likely to come back, so in that way, that's reassuring. But unfortunately, it is a type of breast cancer that can come back even after 5 years, and so it's important to, to educate people about that, to talk about signs of recurrence, but also to normalize. So if there is still emotion or fear of recurrence or whatever years later, that's normal. It happens.
Yeah.
Does experiencing pain heighten any of that?
With respect to even going into surgery, prior to breast cancer surgery, there's actually a lot of data that anxiety, depression, particularly this concept called catastrophizing, is a huge predictor on not only pain outcomes acutely and long-term.
What is that?
Acute pain, so
No, catastrophizing.
Catastrophizing. So it's a concept where let's say the stressors are exaggerated more than they probably should be. And so worries about their own recovery, worries about how they're going to, if they're going to get recurrence, worries about pain. And there's actually some constructs where we've looked at this and we've kind of put it together in terms of an optimistic outlook. There's a tool that you can assess. We didn't do this in breast cancer patients, but in patients undergoing knee replacements, how optimistic you are going into surgery can actually lead to better outcomes, both pain-wise and non-pain outcomes. And so we definitely encourage some level of reducing anxiety, reducing catastrophization going into surgery, but also once pain develops. Pain at a biological level revs up the nervous system and makes you more anxious and more depressed. And those things are bidirectional. So we do have to address these psychological factors from a multitude of ways, and overall will lead to better outcomes over time.
When we come back, final thoughts from our panelists. Welcome back to the Zoomer. It's now time for final thoughts from our panelists, starting to my left.
Okay, so my one take-home point, I think whatever you're feeling, there is probably a formal support out there for you, and making a plug for Wellspring in the community, which just has a host of different supports for people.
I would add to that breast cancer survivorship is kind of the process that comes after treatment, and it's by and large, we think of breast cancer survivorship in itself as something chronic, and there's a lot of supports out there through either Wellspring's Cancer Support Foundation or Rethink Breast Cancer or even Breast Cancer Canada. So I think the thing I would impart to viewers is that you aren't truly alone, and there's always supports that you can turn to if they're not available to you because of access, because of where you're getting treatment. There's a lot that can be found online as well.
For me, I would just like to remind all women, if something doesn't feel right, get it checked out, speak up. If your doctor says, let's sit on it, and you don't feel comfortable with that, speak up. This is your life, and the quality of your life is determined by you, so speak up.
I think what I can say after hearing all these conversations is early detection saves life. You want to minimize your interventions, minimize your treatment, so come and get your screening mammogram. Talk to your physicians. We've dropped the program requirements. People turning 40 can come and have a mammogram at any accredited OBSP site, And we really hope that people will take this to heart.
Do not let fear prevent you from reaching out for screening. Know your body. It is a bit of a trade-off. There is a lot of anxiety, but the distress that I see in women who have to advocate or fight for themselves to get exams, with the distress that I've seen for cancer that has been caught late, far outweighs any anxiety related to screening. That, and you can have great sex after cancer.
My take-home point is that while pain can be common after breast cancer treatments, it is important to get it treated. The longer pain goes untreated, the more difficult it is to manage. It's almost the pain becomes imprinted in the nervous system. So early identification, early referral is important. And most family doctors can manage with early medications and treatment options, but also can be referred to the Mount Sinai Clinic if needed.
I think, it's okay not to be okay, right? And you're not alone also in this journey, and it's okay to ask for help. And, if you don't know where to start, because, sometimes with the first appointment, it can be so overwhelming, right? But, constantly talk to your healthcare providers and advocate for that access to the supports, because they are out there. You just need some support with that.
We've been talking about the many challenges that follow a diagnosis of breast cancer, but there are positive things too. You can come out of it with a new appreciation of your life and what you have in life. It can help you focus on what's really important in your life, and usually that comes down to loved ones, family, and close friends. And it may even give you the courage to make a big change if there's something in your life that is not working. And as our panelists have said, there's lots of support groups if you need help. And that's it for us this evening. To get in touch, send us an email at comments@thezoomer.com. As always, thank you to my panel and to you at home. We'll see you soon. For now, it's time to zoom out.